Good afternoon, ladies and gentlemen. So this is the most important place. I'm just looking for a place to sit. Right, okay. So this is the most important part of the discussion where we take certain technical aspects in relation to the subject that we have already discussed. This is a timely subject. When I was speaking to Professor Manoj here, actually this was kind of the delayed response. Actually we want to be a little bit of proactive in terms of bringing this back to the stage. So I would like to invite the esteemed panelist, Dr. Nimesha Gamheva, the pediatrician, senior lecturer at Sri Jawatanpura University, and Dr. Chandima Siritunga, Director Maternal and Child Health, and Dr. Sanat Akmimana, the President of the College of Gynecologists and Obstetricians. Then Mr. Udadesha Priya. Right. She's here, one of the legal person who will bring the certain aspect of the legality to the discussion. Finally, Dr. Chinta Rupasinghe, who is representing the voice of the civil society for the discussion. So we have a full panel of experts who are bringing different aspects to the discussion here today. So I would like to start the discussion with Dr. Nimesha Gamheva. She's a senior lecturer in pediatrics at University of Sri Jawatanpura, an honorary consultant and neonatologist at Colombo South Teaching Hospital. She is the winner of Professor Priyani Silva Gold Medal at MD Pediatrics in 2016. So I think we have the right fit to the discussion. So welcome to the forum. Yep. Yes, Dr. Gamheva, we have a bit of issue here. This is a very serious issue which has not been noticed to the public much. So as a pediatrician who have regularly seen the patient of this nature, the newborns and families as well, how would you view the implication of continuing pregnancies with confirmed fetal anomalies, both from the perspective of the child as well as the emotional and physical well-being of the parents? Over to you.
Thank you very much for the question as well as for the kind introduction. So to answer that question, I'll take you through what happens to a neonate once the baby is born, and we already know that there is a lethal congenital abnormality. So we all know that lethal congenital abnormality means without our support, the newborn can't survive. And even if we provide the support, we don't know for how long the baby is going to survive. So when these babies are born, I'll give you a couple of examples. Some babies have chromosomal abnormalities like trisomy 13, 18. Some are born without any functional kidneys, and some with severe brain abnormalities, which could be which was shown earlier, an encephaly, holoprosencephaly, a wide variety of malformations. So some of these babies, they die soon after birth, but some of these, actually if you look into the literature and with our experience also, especially if you take a baby with trisomy 13 or 18, although categorized as lethal congenital abnormality, they might survive for months and months. And most of the time, these babies occupy our neonatal space. So they come and they occupy an incubator. And not only that, we need to provide services. Now we will allocate a ventilator, equipment, and there will be staff allocated. And this is all expenditure for our already strained healthcare system. And the most important thing is there might be another baby, let's say a baby born at 27 weeks of gestation, who has the potential to be growing and going home one day with a totally normal child, developmental normal, healthy child. And that baby might not have access to my NICU, because I now have a baby who is now occupied in the ICU for months and months, weeks and weeks. And I know for sure, 100% for sure, that this baby with congenital abnormality is not going to survive, however much we try with this baby. So you see the futility of our efforts as well as our expenditure. At the same time, the implication this is going to have an impact on another healthy baby who might have the potential to go home as a healthy baby. On the other hand, we have a family who is suffering, a mother who has brought this baby up to term and nourished the baby. And looking at all what they go through, we clearly see the stigma, all the mental burden that they carry, apart from the physical trauma. They also have an economical problem at this situation, and I would like to basically emphasize on the psychological trauma or the burden these families and the mothers go through. There's a significant level of guilt they feel. The society will blame, and they might, most of the time they say, this is because of, the karume, it's so unfortunate, this is because of something you have done in your past, in one of your previous lives. This is because of that. This is how these mothers are seen by the community. And this is the truth, because they tell all these things, and they discuss with tears about all these problems. So now you see, in one hand we have a baby who is occupying a newborn unit, and we are using resources, and our healthcare system is already strained, and still we are draining, and we are using our limited resources on this baby, knowing this baby is not going to survive. That's one part. On the other hand, there is a suffering going on. The baby is suffering too. A lot of invasive procedures being done unnecessarily for a baby who we know for sure is not going to survive. And on the other hand, the mother and the whole family is suffering. And thinking about those babies who are anyway going to die, they also have a significant impact on our healthcare system. As Dr. Kapila correctly mentioned, most of our neonatal deaths, second leading cause of our neonatal deaths is due to congenital abnormality. So however much we try, our number will be static there, like what we see for the last couple of years, until we address that process. So as it was discussed over and over by the previous speakers also, yes, we understand it's not a simple thing. It's a very complicated and a sophisticated, very sensitive issue. But the main thing we need to realize is it's not just an algorithm where we diagnose, we terminate the pregnancy. In between, there's a whole set of multidisciplinary input which should come in. We discuss with the parents, and then we offer this as a therapeutic modality, and then we give them time so they can go back, discuss, and then come back to us. So I think most of the women, mothers, would like to have that opportunity given to them. So it's totally up to them to decide whether they are happy to take it or whether they would like to deny it. So that's our view regarding the situation.
Thank you very much. You brought the kind of broader picture in terms of the health of the baby, physical and psychosocial well-being of the parents. So, Dr. Kamya, thank you for bringing the broader perspective to the picture. So, I would like to go further, another step below. So, before before the birth, the mothers are being looked after by obstetricians and gynecologists. So I would like to invite Dr. Sarath Akmimana, the president of the Sri Lanka College of Obstetricians and Gynecologists and past president of the Menopausal Society of Sri Lanka, of course a leading clinician in both private and the government sector. So then the Dr. Akmimana, so this is a kind of given, you understand the gravity of the issue. You may see the patient and the people who are carrying this, I would say it is not compatible, the fetus not compatible with the life. So given in this given current legal and but the social framework in Sri Lanka, how do you as a gynecologist manage the situation where pregnancy is diagnosed with the fatal anomaly, and what are the limitations that you provide? We call it comprehensive care, and what are the challenges? What are the changes that you recommend to ensure women's health, especially the bodily autonomy and well-being as a priority in managing such a patients? Thank you.
Thank you, Dr. Diana. I think your question has three parts. First, when the mother diagnosed with a congenital little abnormality, so breaking the news to the couple is a challenge itself. And you know how shocking the news is, and as well as the impact, as the pediatrician mentioned, the impact on psychological impact and the social impact. So in our setups, managing this type of patients, we don't have any special clinics. Usually manage them in our busy antinatal clinics. And when we reveal this to the abnormality, there are three main things they ask from us. First thing is their knowledge on this are very much limited. First concern is whether this condition will endanger my wife's life. That is the first thing they ask. So we need to address it. And then they ask, what is going to happen? Are you going to take the baby out, or to continue the pregnancy until the delivery time? The third thing they ask is the recurrence. Then the role of dentists come, that we got to get the role. So these are the things we have. So we don't have any special ways to keep them. So what we offer them is, what we tell them is, since the legal system is not allowing to terminate a little abnormality, you have to continue with the pregnancy. And on the other hand, to counsel them, we don't have a proper counseling services in our system. Some places they have some trained nurses, but as a general thing, we don't have counseling services. After that, when they go back home also, they don't have a proper, I think primary care level, I don't think we have any special services to address these issues. As normal midwife, they go the usual visit, but not to see them frequently. But what we do right now is we see them frequently in our clinics, and whenever there is some concern, they can come back to us and talk to us, and we advise them. They feel that the baby is not moving to come and get admitted. So the delivery plan is as usual. There are two ways of delivery. That is, once they reach the viability of, couple of said 28 weeks, now it has come down to about 26 weeks. We can offer, if they willing, can offer to terminate the pregnancy, not termination, see induction sort of thing. Or else wait until spontaneous onset of labor. So it's a huge psychological problem, because they are carrying not viable or not productive fetus inside, and suffering continues. And then sometimes this suffering, so psychological impacts are lifelong. But we don't assess what happened after delivery and on. So the risk of inducing labor after 20 or 26 weeks or something is difficult, because sometimes can end up with an operative delivery, unless they don't deliver with all our interventions. Best thing is to wait till 40 weeks. As Kapila said, sometimes these anencephaly babies, they won't go into labor easily. They won't deliver easily sometimes. Even if it's the second pregnancy complicated with the previous cesarean section, we might have to deliver by cesarean section. So that might hamper their future fertility wishes off. There are many issues. Continuation of pregnancy. So the challenges, those are the challenges we face. But the changes I want to tell you is, if we can legalize the termination of these pregnancies, especially the lethal congenital abnormalities, there are many benefits, as Kapila and Mr. Kunle mentioned. The impact on their lives, socially and psychologically, even the health sector, various aspects, is very helpful. More than figures, I think these are very important. And establishing counseling services to look after these people, because they are suffering, nobody is bothered. Not bothered, but we are helpless. Even though we are bothered, we are helpless how to help them with our service provision. Third thing is, and we have to look after their psychological status. We have good psychiatric services currently. So then and there we refer them once or twice for a session with the psychiatrist. We have mental psychological issues, they can have responsibilities. And the reference to general system to get the feedback for the future pregnancy. I think those are the basic things. I think I have addressed your question there.
Yeah, Dr. Akman, I have another additional question, additional things to clarify. In terms of diagnosis, how is this diagnostic tools that is available in the island wide are accurate to diagnose these type of anomalies at the very beginning? Do you have any kind of comment on it?
Good question. That is something we need to look at, because there are now subspecialties coming up, the fetal medicine. So most of our consultants are capable of diagnosing common congenital abnormalities, and some of the radiology ultrasound scan machines are not up to date. The clarity is poor, but still they diagnose. Once they diagnose, what they do is, there are few specialists, even though the subspecialty was established, there are specialists who do fetal medicine. So we refer to them and get their opinion to make sure that is what I've diagnosed. Obvious things like an encephalopathy, there's no difficulty in diagnosing it, but there are certain things of congenital heart disease need to get their opinion. So.
Okay, thank you, Dr. Hamam, bringing another perspective to the table. So now we know about the perspective from the pediatrics, then we know perspective from the obstetrics angle. So now we are moving to another direction by introducing Dr. Chandima Siritunga, the Director of Maternal and Child Health of the Ministry, and he has a decade of experience of being a provisional director at the provisional level and the MOH at the grassroots level. So you have been dealing with number of cases and different level and different capacity. So actually the maternal and child health program is kind of a family health bureau actually looking after the larger area of maternal and child care. So from your perspective, from the maternal and child health system perspective, how would you see current gaps in care for women carrying fetus with lethal anomalies? What kind of policy and programmatic responses do you think to need to ensure women receiving medically appropriate, compassionate and timely care in Sri Lanka? Especially, are we actually providing a bigger public health kind of services to the grassroots level through the midwifery and other things? Are we compassionate on it? How best we can improve these services? Do we have any kind of thoughts on it?
Thank you, Rana. Now, I think for your first question, Dr. Nimasha and Dr. Bhimana both given introductory kind of answer, because as the VOGs diagnose these cases in utero, but I don't know whether using these anomaly scans and various these things, but diagnosing without a proper solution, I don't know whether you have to elaborate on that, because I don't know what are the, and then once you diagnose this, the emotional impact and these things are there. So we don't have a system, Dr. Dana, in our system to do this, even the counseling, the psychiatric support and various psychological support and various things. But as previously discussed, the mothers keep this going without hope. And even once after the delivery, even as it was also mentioned earlier, that we have to keep these babies for some time using the current resources, the impact of the health system that has been discussed. And even after that, we don't have such system to intervene in it. So I feel in our health system, first we have to use our current system in the preconception care to diagnose these cases, to counsel before the diagnosis, to prevent this occurrence, whether we can include the counseling, the genetics and all these things to our system to prevent congenital allomancies occurring. That area we have a gap at the moment because our current health system does not offer that service. So whether we are in a position to introduce that. And the diagnosis purpose, I don't know, without a solution, doing these anomalies scans that Dr. Kimana will be able to elaborate on this. And once the diagnosis, if we are to continue in a current aspect, I think the counseling, the psychological support, these things are to be strengthened. And definitely we have to consider considering the cultural and this religious and all these aspects in the current framework, what can be offered using the legal framework that has to be there. So we don't actually in the field level or within the curative care institutional level, we don't have a proper system to tackle this issue. Yes, thank you.
Okay, thank you. I think you will be, you may have to share your thoughts in the kind of the subsequent sessions. So then I would like to thank you, Dr. Chittako, for your very informative the elaboration about the public health aspect of the issue. So now I'm going to turn to another different aspect of the discussion. Throughout the forum, it was, the legal issue kind of showcased as one of the key barriers to address this one, especially the policy and kind of policy level changes, legal, the penal code level changes. So those are the things that came to, to the discussion. So we have Uda Deshapriya, a young attorney at law with masters in human rights. Uda has worked in gender equity and sexual and reproductive field more than 10 years and national as well as the international organization. Uda, very importantly, Uda is one of the members of Safe Abortion Coalition Sri Lanka. So you may have a lot of things to share in this forum, but I would like to focus your attention to this particular issue in this manner. From the legal standpoint, how would you how would current laws in Sri Lanka address or fail to address termination of pregnancy? What are the legal and constitutional changes or opportunities that exist for reforms, and how can legal system better align with these medical realities? You see the numbers during the presentation. So with these medical realities and human right obligation in cases of lethal anomalies. Over to you with that. Yeah, why not? Yeah.
I have some slides, so I'm going to speak from here. Distinguished guests, organizers, colleagues, thank you so much for having me. Today I'm going to talk very briefly about the legal framework around abortion in Sri Lanka, and I'm not from a medical background, so I'm going to consistently use the term abortion, and if it distresses any one of you, I apologize in advance. So Sri Lanka has one of the most restrictive abortion laws in Sri Lanka. If you look at other countries in the region, there are multiple grounds on which abortion is legal. A primary piece of legislation about abortion law in Sri Lanka is the Penal Code of 1883. Section 303 talks about causing a miscarriage. Basically, it criminalizes seeking or providing an abortion except under one ground, which is saving the life of the woman, done in good faith. The next section, which is 304, talks about performing an abortion without the woman's consent. So this is a situation of forced abortion. Then the next section, 305, talks about death caused by an act done with the intent to basically perform an abortion. I have to tell you, when you talk about constitutional barriers, because of Article 16 of the Constitution in Sri Lanka, all existing law is valid even if it discriminates or violates fundamental rights of Sri Lanka. So these laws can only be changed through an act of the parliament. And this is a challenge because this sort of prevents the evolution of law with our understanding of human rights, with our advancement in the medical field. 1883 was a time before independence, it was a time before universal franchise, it was time before in Sri Lanka women were not accepted into neither legal or medical profession. And at this time, abortion was a very dangerous procedure, but now with the advancement of medical abortion, it is relatively a very safe procedure. So things have changed. But because of Article 16 and Article 83 of the Constitution, we need an Act of Parliament to sort of change this. Then when we look at the Code of Criminal Procedure, places a mandatory legal obligation on the public and public officers to report certain crimes. And this section particularly excludes 303. That means in Sri Lanka, there is no mandatory legal obligation either on providers or on the general public to report instances of abortion. In Sri Lanka, post-abortion care is legal. In fact, the National Guidelines on Post-Abortion Care 2025 provides healthcare providers with essential information to provide post-abortion care. Post-abortion care has been used in many countries as a harm reduction methodology to reduce morbidity and mortality resulting from unsafe and illegal abortion. When we talk about legal reforms, it's really important that we address legal reforms from a point of human rights. So gender equality is a fundamental right, it's a human right, it's very well established. So you may ask, why do we need abortion for gender equality? Men don't have a right to get an abortion, so what's the relevance? Yeah, but women and people who get pregnant have disproportionate health outcomes in terms of their physical, mental health, economic outcomes, social outcomes because of pregnancy, childbirth, and motherhood. And therefore, not having access to safe legal abortion actually makes the playing field uneven. So for women to be able to decide when they can have a pregnancy, when to get pregnant, how to get pregnant, how many times to get pregnant, whether to get pregnant, without being able to make those decisions, actually for women, the playing field is uneven. And that is why for gender equality, having access to abortion is absolutely important. Then I want to look at some of the human rights instruments in Sri Lanka. Not in Sri Lanka, I mean international human rights, treaty bodies and international human rights instruments. So CEDAW committee has recognized the right to abortion as a human rights concern as early as 1999. So here it says, in the second one, 2017, they basically say denial of abortion may amount to torture, cruel and inhumane or degrading treatment. I'm not going to go through these in detail. These are just some highlights. There are many, many instances where international human rights treaty bodies have recognized the importance of access to safe abortion. So with regard to adolescents who are pregnant, the Committee on the Rights of the Child has at least on 2 instances said that basically pregnant adolescents need to have right to safe abortion. These are some highlights from 2023 and 2026. and the Committee on Economic, Social, Cultural Rights in General Recommendation 22 and Human Rights Committee in General Recommendation 36 have also highlighted that state parties must ensure that people have access to safe, legal and effective access to abortion. These are some of the case law from international human rights courts. So one of the challenges with regard to enforcing these rights in Sri Lanka is that Sri Lanka follows what we call the dualist legal tradition. That means international law does not automatically become enforceable in Sri Lanka without some kind of a domestic adaptation through law. However, this can be used in persuasive authority. Some cases, for example, in 2016, have used international human rights instruments such as CEDAW in their judgments, but it is not binding essentially. So in these three cases, LC versus Peru, LMR versus Argentina, Camila versus Peru, the courts, the international treaty bodies, CEDAW Committee, Human Rights Committee, Committee on the Rights of Child, have actually given really progressive judgments on abortion and how abortion is really important for human rights. In the cases Camila versus Peru, this was a case of incest. Sexual violence was perpetrated by the survivor's father, who was 13 years old. The girl was 13 years old. And the state basically denied her information on abortion and access to abortion services, even though at that time therapeutic abortion was available in Peru. And basically the committee held that the state has violated the rights of this plaintiff. So these three cases, I've highlighted them because they are particularly about cases of lethal fetal anomalies. I'm not sure of the terminology, it's also called FFA, fatal fetal anomalies, so FFA. In these three cases, KL versus Peru, Malay versus Ireland, Whelan versus Ireland, the courts actually go into a lot of detail about the grief and suffering of the families, as well as very strong legal arguments for law reforms. The second and the third cases from Ireland actually led to reforming the law in that country. So I highly recommend that in your policy briefs, in your legal reports, please look at these cases because they provide amazing arguments and really documents the experiences of families when there are unviable pregnancies. So thank you so much. This is the end of my slides. I would like to highlight that abortion should be a human right accessible to all, and maybe to stop with something positive, right? Something positive. We recently did a survey of justice sector employees in Sri Lanka, and we asked, do you think abortion should be decriminalized in Sri Lanka, at least in cases of rape, incest, fetal abnormalities? And can you guess how many people said yes, agree? Can you give a guess? 50? 60? 20? 84. More than 84 said yes. Because these are people who come into contact with survivors, these are people who come into contact with the justice sector, so they are sensitive, they understand the issues with regard to access to abortion. So these are some positive indicators that we can think about, and we can be hopeful about the law reform. So thank you so much. I'm happy to answer any of your questions.
Thank you very much, Ida. You brought us totally different perspective to the table. So I think this is very important because the legal aspect of this issue is one of the key things that we have to sort it out from the very beginning. Now I would like to focus the attention to the civil society. Dr. Chinta Rupasinghe, Director of Sexual and Reproductive Health at Family Planning Association Sri Lanka, is here with us today. She has over a decade of experience of reproductive health system, community-based and public health, as well as the humanitarian responses. So, Dr. Chinta, I would like to focus your attention to the role of the civil society in this whole. So most of the time we see that pressure that is coming from the civil society is very much reflected in some of the more progressive policy reforms. Because initiation are coming from the civil society, that civil society voice is being powerful enough, when it's powerful enough to grab the attention of the policymakers, they will positively respond. So I would like to ask organization and the person who are mostly active about the kind of the rights of the women. So then in this case, what is the role of civil society to bring this on the back to the table of policy making, and as well as what are the how the advocacy effort would be strengthened to approach the reproductive justice and access to compassionate care.
First of all, thank you to the College of Community Physicians for bringing this topic, timely topic, into for forum of discussion. And I think we have to admit the very this problem from the point of view of the civil society. We have to acknowledge the mere bitter truth that many women has undergone this silently through this undue pain of carrying a fetus that is not viable, going through the pregnancy, going through the childbirth. It is not only the physical trauma that they endure, it is the mental trauma. And this is where the civil society organizations should come in, because these women, they bear it voicelessly, powerlessly, silently. This pain they endure, they go through because we have a legal framework that prevents them from reaching a solution that is compassionate and gives them due justice they deserve. And as civil society organizations, we should be able to give a voice to these voiceless women. And as a civil society organization, Family Planning Association has been there for more than 6 decades in the country, working with women in different socio-economic backgrounds. So we have our counseling services. Likewise, Dr. Kapila mentioned in his presentation, we see the tip of the iceberg as suicides, maternal suicide. We as counseling service providers, we see the rest of the iceberg actually. We get women walking into our clinics, our service delivery points, reaching the counseling services who has endured pain of this, going through the pregnancy, losing the child, at the end of pregnancy, going through the pain of the childbirth, with all the physical pain and physical risk, health risk and complications, ending up with sometimes weeks, months long hospital stays, premature baby unit stays, and ending up with no child in hand. That is an immense mental trauma they are going through. We have seen it over many decades that how many women go through this pain. So we have a moral obligation, especially the organizations which work in sexual and reproductive health context. We have a moral obligation to bring a voice, to bring into the forums, because these stories, these are not mere stories. These are not just abstract stories. These are human experiences that our sisters, that our mothers, that might be our friends have gone through. So these stories need to bring into light. So that's how these stories can change the minds of policymakers, the people who have the ability to change go into the reforms of this termination legal framework. Then that is our responsibility, I guess, as civil society organizations, and also how we can do it. That is the most important issue we have it at hand. I think in a way, the Family Planning Association, we have done multiple community-based researchers, especially collecting stories. We have collection of termination-related stories published a few years back, but I think we need more numbers, more statistics in this arena. And for the other thing is, we need to get into it together and not to polarize the issue, not to politicize the issue, just to make sure that this is a collective effort of legal, health, civil society, faith-based, everyone, to make sure that this intervention needs to be there for better public health outcomes. As a country, we need to make sure that our public health indicators, our numbers, and also we should not forget about the socio-economic impact of this as well, because this is economically active working population we are talking about, who undergo they given the choice, they might not go through the whole year of pregnancy, whole period of pregnancy, making them suboptimal workers, suboptimal economical active people. They might not go through this, so we have to consider that as well. So, and that is our, as civil society, that is our obligation to bring into the light these stories, this impact, the impact we can make in the policy making forums. And finally and foremost, I think if we are to legalize the terminations, the mental health counseling service provision, it should be definitely included, because we have seen the pain they have gone through. We have seen our counselors have supported many women to navigate this type of difficult situations. So we know how difficult it is. It is the rest of the iceberg of maternal suicides. So I think this is our obligation, not just to be mere observers or advocates. We have to be allies for all women to go towards this reproductive health justice and to receive the due care and health service provision they deserve. I think that is what is expected from civil society organization.
Thank you, Dr. Chinta. You really articulate the role of the civil society in creating the pitch for the kind of other policymakers and other whatever the relevant authority responds. So, again, thanking you for the excellent explanation. I would like to open the floor, but as I don't know whether Dr. Kapil will allow me to conduct this continuous session. We are 40 minutes behind the schedule, but still this is a kind of more kind of very important forum and important discussion, and we have a number of experts who have been working in this sector for a long time. I can be Dr. Susi, then I can see Dr. Hemant and a couple of other people here. So then I would like to open the floor, make it brief as much as you can, then you can accommodate more and more questions in this forum. So can someone pass the mic to the person there? He wants to do something first. And second, we will go to Dr. Susi.
Hi everyone, thank you so much for organizing this dialogue. It's very much needed. I'm Sonali Silva, I'm the director of Yield Hub. And what I'm noticing is that on this panel there isn't the youth perspective, so I'm going to be offering you what young people have to say about this issue. I have a deep reverence and respect to doctors like Dr. Kapila, Dr. Susi, others from the College of Obstetricians, the Family Health Bureau, because year after year we come to the same space, all of us gather here today. And we've been doing this from 2019. We know the evidence and we try to get very creative about what we are really asking for. And what I would like us to do is to actually not tiptoe around the issue. We are scientists, we are researchers, we are young professionals. We go by the evidence, and that's what we prioritize, not necessarily what is easy to talk about. So let's not be afraid of the word abortion. Let's not be afraid of what is really needed. I think the other thing that I noticed is that there was a speaker that mentioned that, it's not something in public discourse. It's not something discussed. But respectfully, I have to disagree, because young people, as Uda mentioned, young professionals in your own cadres in the health sector, similar to the justice sector, 86% of young professionals in the healthcare sector support this, support abortion, because they don't want to see their own people, Sri Lankans, suffering. So young people in your own sector will stand by you, and this is a moment for you to be brave. And so, just to reiterate that there is a strong public discourse on this. We all want the same objective, Sri Lankan people that have the chance to protect their lives, to prevent harm, and to live with dignity. Yeah, that's all I want to say. Thank you.
Thank you. Thank you for bringing a perspective of the youth into the table. And it's same time, thank you for an energetic comment. I think, shall we move to Dr. Susi as the next speaker, and then we will come to the Susi.
I'll be very brief. I think there has been among the professionals probably a difference of opinion in the past, but now I think the clinicians have very well articulated their dilemma, and the health burden is definitely understood. And it's just that I think even last year there was a similar forum. I mean, practically all the relevant professional colleges have included this on their scientific agendas. And last year, the decision was that we, the professionals, if civil society comes together, that's good, but we take it to the public and we create this, understanding that there are things that we can offer, right? We had one full symposium on the genetic side of it, so there are things that can be offered, and we see that the legal framework can be changed, so let's put pressure, let's do that, and we take it to the decision makers for them to make the change.
Okay, thank you very much, Dr. Susi. Again, I don't think that is a kind of question to anyone. Shall we go with this gentleman? So
I'm Hemant Sen, and for those of you who don't know me, I'm an obstetrician. I've been working in this field for a long time. I apologize if I'm repeating some of the things that were said before I arrived. There's a saying in women's health that a rich woman will procure a safe abortion, and that's true even in this situation, right? And I think there is a lot of hesitancy that has been shown in this, a lot of negatives that have been shown, but following on from some of the comments that were made, I believe firmly that we can't be telling women to go looking for counselors. Somebody from Polonnaruwa can't come to FPA, etc. It's the obstetrician, I think, who is the best to counsel these people. But coming to abortion, I have been in this field for a long time, and I have seen this going to Parliament on multiple times and getting shot down, right? I think the weakness is we are saying we will do this for abnormalities, incest, rape, etc. However, these are very difficult things to do, and even for rape, how are you going to prove rape? You take 10 years, the child will be going to school. So how are we going to sort that out? I believe that, like some of the other people are saying, I come from a position that the abortion should be considered by us now, in this context, today, as a woman's right to her body. And it's controversial, but I think we have to. I'm surprised by that. Thank you. But really, I think, trying to compartmentalize it and trying to be specific, I think we are making it more difficult, really, and I think we have to change our attitude, and congratulations on continuing this dialogue, and we have to take it forward. Thank you.
yeah, thank you so much. Actually, a number of occasions, the women's bodily right has been brought into the subject again and again. We have to put more emphasis on it. We will take another couple of questions. Questions or comments. Yeah.
Just give me 2
Just-
minutes.
Okay.
The technical dialogue for last 2 to 3 decades have proven beyond doubt the need. But the issue is, this technical dialogue has not been successful in pushing for legislation. The question is why? I am looking from a very different angle. I am thinking it is not the technical details or the evidence. It is the lack of political will throughout that has not been successful to get it pushed. So we can have 101 discussions like this for next 20 years. But the real thing will not be done unless you will tap on the political will and to make sure that the political will finally push the legislation to get it enacted. And how we are going to do it? So this discussion needs to go beyond a technical discussion to the political discussion and the political activism. If that does not happen, we will in 20 years' time, in the same forum, we will be discussing it again. Thank you.
Thank you, Manoj. Actually, over the last 2 weeks and even this morning, 2 weeks back, we all met Honorable Minister of Health, and he pledged his support. And this morning we met Minister of Justice. So he also was very positive. So now now I think the political will is there. Now that is why we need to push it forward from the academic or this professional side and get it done.
Thank you. Thank you. Yeah.
Hi, good evening. I'm also a legal professional, and looking at Dr. Kabila's presentation and what was presented here, there seems to be an issue of public perception and narrative around abortion. And you also shared some misinformation by media professionals. So I want to, and also when it comes to public perception, the only opinion which you seem to seek is those from religious leaders, so men who can actually never get pregnant, let alone even supposed to be having sex in the first place. So I want to ask a question from you. Besides engaging with religious leaders, is the medical community and fraternity doing anything to educate media professionals and journalists on how to change the narrative around abortion and to win public perception on this? Because what I've seen with our political leadership is that if they don't feel the public is behind it, they will tell you in a meeting room that they support it, but like how they're absent at this meeting, they won't come publicly to say they support it. So you have to change the public narrative. So I want to ask a question, what are you doing to, or is there a plan to engage with journalists and media professionals to change this?
Yeah. Who wants to answer? Yeah, I think let me briefly answer the issue that is raised by this gentleman. Actually, we met with the two colleges and the some of our UN representatives with the minister. Even that forum, it was really articulated that the training of media people and bringing civil society back to the discussion. So actually, that's what I'm telling you. At the presentation of the here. So the civil society and the media should collectively put up the pitch for the politician to act. So because the politicians are politicians, they are really scared of their vote base. So therefore the public should be given enough pressure. So civil society movement should give enough pressure them to enact whatever the things that they want to take it forward. So that is actual primary responsibility of all of us. Shamala, waiting for a long time. So can you kindly pass the mic to you?
Thank you, Diana. I'm Shamala Gomes, and I'm a lawyer. by training. I used to teach at the law faculty for many years, and I moved out, and I'm now with civil society, and I've been working in this sector for around 30 years altogether. And I just want to kind of bring in a few things. I mean, there are many things I want to talk about after listening to this distinguished panel. And while I agree, and as a lawyer, and we've been advocating for many laws, for many reforms, including the policies as well as the laws in different aspects, for example, sexual and gender-based violence, land rights, transparency, accountability, etc., etc. What we see is that broadly, there is no consultation, there are not enough consultations being done by the government to talk to various stakeholders. If you don't mind my saying this here, abortion is not only a medical issue. It cannot be seen only through a medical perspective. I think it's really important to look at the broader dimensions. And I think also one of the things as a lawyer that I'm particular about is terminology. And the fact that terminology, for example, using anomaly, abnormality, fatality, lethal, abnormal, all of these is mind-boggling, and I think can arise in many situations subsequently as well. So, like the way Dr. Senaraika mentioned, I think it's also important to look at what is the objective here, right? And we're looking also at the fact that this is a human rights issue. Finally and foremostly, it is a human rights issue. And I come from that background, and I'm sure many of us here do, but we kind of seem to lose the plot when we are talking about all of these issues. And I think this is something that we need to, it cannot be one-sided. It is not only looking at what the medical profession says, but also looking at globally what have been the successes. It's not only in cases of fetal abnormalities that laws have been changed. There have been other reasons too. The main point I'm making, Diana, is we need consultations with different sectors in this process here. It's not what the minister said this morning or what he heard from the medical profession, but for many of us here who have been working in this sector for so many years and have also met women who have been raped and I have no choice but to keep a baby, who have been incest has been committed, and our law was changed in 1995 to reflect that criminal offense.
Yes, Shamla,
what are those situations?
Shamla, actually we should be mindful of the time.
That's fine. Thank you very much, Diana.
Thank you for your very elaborate discussion. So I have one final thing. Let's go to the Professor Amruti. After that, we are going to close the session for a while. We may have a lot of other forums to discuss this and bring the discussion forward.
I'm Professor Amruti Singer from Forensic Medicine, and in my own life, this is the, if at all, Kapila, I was in many committees in 2014 also. We kept it going up to the parliament. But somebody, even if we failed at that time, somebody has to take up this torch, as Shamala said, get everybody to do that. I hope from the history they said in 70s, Medical Legal Society pushed it, failed. Then in 90s, College of Genenops pushed it up to the parliament, failed. Then in 2014, that's the time I was also going every committee from health as well as children and women's ministries. Even there are possibly good signs about this government. Kapila, somebody has to take it up and carry. So at least you have started with the considered part, but I feel coming from the rape and those victims, it's a human right need that has to come in. Somebody has to push this. So let's again, the taking up till it is over, that momentum building. If you have started it, carry on and we will support you, but getting everybody is a challenge and time consuming. I don't know whether we will have it till we retire.
Thank you very much, madam. So, unfortunately, we know that you have a lot of ideas to share, comments to give. So, but unfortunately, time is the limiting factor. So, we will meet in another forum. So, before wrapping up the session, if I would not give a chance to my own colleagues who are sitting in this in front of you, it's a kind of I think it's a some mistake. So, I would give you each of you 30 seconds to give your most the key take home one message from Sanat.
I think I will take only 10 seconds. I think determination is a must, and I think we must, as the suggestions came from other the consultants in this forum, like we need to get the support of the public as well as the other political people, because this issue can be a political change, can change the political culture. That's what happened.
I think from the Ministry of Affairs side, we are the responsible party and we are the, so we do our part.
So we see how the babies suffer, we see how the mothers suffer, so let's stop it. We are in a good place. It's amazing to have these conversations. These discussions are really important. So let's continue to have these conversations, and lots of gratitude for creating this space.
I think termination is a matter of country, not only women's rights, it's a matter of human rights for all. The family, the husband, children, for all. So we need to take this forward as allies towards compassionate and proper public health intervention. That is my view.
Okay, thank you so much. Actually, this forum brings a lot of discussion on legal and policy reforms, especially psychosocial, psychological care, including counseling, obstetric care, then the pediatric care, same time the civil society involvement, as well as the youth involvement, and political involvement, and the mass media involvement. So that's a kind of, I'm trying to do everything within 30 seconds. So I would like to invite Dr. Kapila to, pardon? We'll close the session. Okay. Thank you so much. Then we'll go for the next one.
Yes, thank you very much to all our panelists and also to the esteemed audience that have generated thought-provoking things, and these things are normally often overlooked, but also which needs often and also needs real policy as well as health system attention. Your insights have helped to frame the complexity as well as the humanity behind this topic. Ladies and gentlemen, now let me invite Dr. Kapila Jayaratne to present the tokens of appreciation to our panelists. Starting with Dr. Nimesha Gamheva, Dr. Chandima Siritunga, Dr. Sarat Akmimana, Ms. Uda Deshapriya, Dr. Chinta Rupasinghe, Dr. Dayanath Ranatunga, and also Mr. Kunle Adeni. I want you to come forward to the stage to receive your token of appreciation, please. Ladies and gentlemen, let's give a big round of applause. Ladies and gentlemen, so that concludes the colloquium on termination of pregnancy in situations of congenital lethal malformation. This colloquium has helped you to Ladies and gentlemen, please remain seated for our next event. We are going to have our closing ceremony